Hello, my name is Suzette Davenport, and I'm a nurse practitioner and work at Atlantic Breast Associates, a physician-led practice within Atlantic Health System that's located in New Jersey. The majority of the patients I see in practice are at a high risk for developing breast cancer. I recently completed my DMP scholarly project of implementing the Tyrer model in a gynecology practice to identify women aged 25 to 40 who are at a high risk for developing breast cancer. I'm very excited to share my project and the outcomes with you today. According to the Young Cancer Coalition, breast cancer is the most common cancer diagnosed in women under the age of 35 worldwide. And the United States Centers for Disease Control and Prevention estimate that 1,000 women under the age of 40 will die of breast cancer each year. And despite the new National Comprehensive Cancer Network guidelines, a breast cancer risk assessment is not regularly performed on women under the age of 40. Average age of consultation for high risk usually is about 46 in our practice, and the majority of the consultations are originating from the breast imaging centers. So when I looked into the research, I used Sinol literature to identify common themes regarding the topic. They included the need to educate providers about breast cancer screening guidelines and risk assessment tools. The literature also noted that risk assessment should be conducted during the clinical encounter for women aged 25 to 40 using the TC model. This TC model is an accepted and validated tool for the younger population. The project did follow the knowledge to action framework, and you will see on the bottom of the second column is the process workflow map that was used to guide the implementation. So following an educational session, the TC model was implemented into the gynecology practice setting for 3 consecutive months. Risk assessments were performed on women aged 25 to 40 during an annual Well Women visit. The providers managed risk scores in accordance with NCCN guidelines. A pre-implementation chart audit revealed that the risk assessment hadn't been completed. Post-implementation showed that 68% of the women had a risk assessment completing during the implementation time. 11 women were identified at a high risk. The risk wasn't completed 100% of the time, and this could be related to the fact it is a new task. There were also staffing changes. New providers were starting midway through that implementation time. It is also not built into the electronic medical record known as EPIC is what we use. However, it did demonstrate that CMAs can perform the risk during a Well Women visit, thereby allowing the providers time to focus on the risk assessment in accordance with guidelines and referrals as needed. We are looking to sustain and expand this implementation into other gynecology practice settings and primary care practice settings, and hopefully build the assessment into EPIC, which can help embed it into practice. That concludes my poster presentation. You will see a QR code for my references as well as the 2025 NCCN guidelines for high-risk patients. Thank you so much.